Very good evening, dear all. This is Dr.Sepuri, endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Karnool. So it's a very happy evening. Especially this is the first speaker program for 2023 actually. So today we are going to talk about the DPP4 inhibitors in the perspective of the Linagliptin actually. The topic being the optimizing type 2 diabetes management with DPP4 inhibitors through patient-centric approach. And thank you so much, the Lupin Diabetes Care, the technical team, and the RSM, Mr. Naveen, for your kind introduction. So I request all the participants to type the questions or queries in the chat box so that we'll take it up at the end. So with that, so today we'll get into this very important, clinically relevant topic, the optimizing type 2 diabetes management with the DPP4 inhibitors through the patient-centric approach.
Sir. Hello.
Hello?
Sir, any issue, sir?
Yeah, the slides are not moving actually.
Hello. Sir, you can change with your keyboard wheel, right and left key, sir.
Yeah, I've tried right and left also. It's not moving actually. Before the beginning of my talk, the slides were well moving actually.
Okay. Okay, sir. Can you reset this?
Yeah. Kashish, I am going to stop the now sharing. Now I am going to share once again.
Yeah.
No.
No. Yeah. So thank you. Okay. And this is a very busy slide showing the decision cycle for the patient-centered glycemic management in type 2 diabetes. So in the center we see the goals of care, and the aim is to prevent the complications and to optimize the quality of life. And this particular the preventing the complications and optimizing the quality of the life is dependent on multiple factors which are given, like from starting from the top left. See the review and agree of a management plan, that is they review the management plan and the mutual agreement on change and ensure agreed modification of therapy is implemented in a timely fashion to avoid the clinical inertia, and the decision cycle undertaken regularly, at least once or twice a year. And coming to the assess key point characteristics like the current lifestyle, the comorbidities like atherosclerotic cardiovascular disease, and the chronic kidney disease and the heart failure, and the clinical characteristics, that is age and the HbA1c and the weight, and issues such as the motivation and depression, and the culture and socio-economic context, and the ongoing monitoring and support, including the emotional well-being, the check tolerability of the medication, and they monitor glycemic status, and biofeedback, including the blood glucose monitoring, and the weight, step count, the HbA1c, and the blood pressure and the lipids, and consider the specific factors that impact the choice of the treatment, that is the individualized the HbA1c target, and impact on the weight and hypoglycemia, and side effect profile of the medication, and the complexity of the regimen, that is the frequency and the mode of administration, that is to they minimize the polypharmacy actually, and choose the regime to optimize adherence and the persistence and the access, cost and the availability of the medication. And the implement management plan is the patients not meeting the goals generally should be seen at every 3 months as long as the progress is being made, and more frequent contact initially is often desirable for the diabetes self management education and support. This is nothing but DSMES. It's a term by American Diabetes Association. And agree on the management plan, that is, they specify the SMART goals, that is, the S stands for the specific and the M stands for the measurable, A is achievable and R is realistic, and the T is the time limited. You can just remember the SMART goals. And coming to the final, the factor that is very much important is the shared decision making to create a management plan, like that involves an educated informed patient and their family or the caregiver seeks the patient preferences, and effective consultation includes motivational interviewing, goal setting, and the shared decision making, and empowers the patients and ensures the access to the diabetes self management and education and support. Next slide, please. Kashish, next slide, please.
I will hold. Hello. Hello.
Hello.
Sir, can you see it, sir?
Yeah, I'm not able to.
I have already changed the slide, sir.
Acha, okay. Now it's visible, okay. Yeah, I think I can do it. I think, okay, it's moving. Thank you, Kashish.
Yes, sir. Thank you.
And this is a very busy slide, the bar diagrams, which show the ICMR INDIAB 13, that is the 2022, that is a study done by Dr. Mohan and the Anjana et al. The poor glycemic control seen across the urban and rural India. And you can see the graphs actually. See, there are 5 bar diagrams in each of these 5 bar diagrams you can see. That is, first one is the urban and the rural, and the male, female, and the last one is overall. You take the parameters like the first one is the glycosylated hemoglobin less than 7%. You can very clearly see all the bar diagrams, whether it is urban or rural or male or female or overall, it is like 34.8% and 35.5% and 35.7%, 36.8% and 36.3% respectively, with regards to the A1C goal of less than 7% as per the American Diabetes Association, the standards of medical care in diabetes. So it should be around or less than 7%. So coming to the blood pressure, that is at least now it should be meticulously maintained. There is no second thought. Even the American Heart Association and the American College of Cardiology, they have made a common consensus, and the results rolled out in 2019 by the chairman of American Heart Association, Professor Dr. Paul Welton actually. So though the cutoff points vary from the American scenario to that of the European scenario, but the target goal remains same, that is less than 130 bar systolic and less than 80 diastolic. So here less than 140/90 also we see at least like less than 50%, less than 50% of the patients are maintaining a blood pressure of less than 140/90 millimeters of mercury, that is starting from 46.4% to 50.9%, whether urban or rural, and the male, the 48.9%, and the female 48.6%, and the overall it is 48.8%. That is less than 50% of the patients are maintaining. Even this is not the desired, this is not the target goal. The target goal is always the less than 130 bar 80 millimeters of mercury in most of the adult patients, barring the patients above the age of 70, above the age of 80. And coming to the total cholesterol, that is the less than 200 milligrams per deciliter, this is also like one third of the two-thirds of the patients are to the target, like 65% 0.9% and 61.9% and 67.8%, 59.4% and 63.8%. So, and coming to the triglycerides, so as far as the guidelines of American Diabetes Association, the triglycerides in patients suffering from diabetes must be less than 150 milligrams per deciliter. So you can see at least less than half of the overall patients are maintaining the triglycerides to a target goal of less than 150. Like you take the urban, that is 48%, and the rural, that is 49.5%, and the male 46.4%, and the female 51.5%, and the overall is 48.8% respectively. And coming to the last parameter, that is the LDL cholesterol, which is very, very important. And they said in 22 ICMR INDIAB, they had put it as less than 100 per milligram per deciliter, but the latest the lipid guidelines have rolled out that the no more 100 is sufficient for a patient suffering from type 2 diabetes. It must be meticulously maintained below 70 milligrams per deciliter. But even in otherwise also, according to the old guidelines, less than 100 mg per dl at least. See, less than 40% are maintaining to a tune of this particular the LDLC goal of less than 100 at least. That is the urban being the 42%, and the rural being 41.1%, and the male is 46.2%, and the female is 36.3%. Very, very pathetic actually. The females are maintaining the very high LDLC when compared to the other parameter categories which are mentioned, and the overall is 41.5%. So because all the time we need to target the LDLC, which is the culprit for the atherosclerotic cardiovascular disease. So with that, so the inference is that around 64% of the Indian type 2 diabetes patients do not attain the HbA1c target of less than 7%. That means only one third of the Indian patients are able to maintain the target A1C of less than 7%, and around two-thirds are above the target, which is a pathetic point to note. And coming to the next slide, which shows this is we see it very, very commonly and very regularly. This is the pharmacological treatment of the hyperglycemia in adults with type 2 diabetes. This is always given in the first volume of the diabetes care, January every year. At least from the last I think it's been there from last 1986. They have been releasing the guidelines actually. Every year we get the guidelines, and we got the latest guidelines also. The 2023 guidelines rolled out in the December itself, and you can get into the net and you can download the guidelines. No much difference is there, but okay, as far as the pharmacological treatment of hyperglycemia in adults with type 2 diabetes, this is the algorithm of treatment So that is the stepwise approach with the risk factors. There's the atherosclerotic cardiovascular disease, or the presence or absence of the heart failure, or the presence or absence of the chronic kidney disease, and so no comorbidities, like no ASCVD, no HF, and no CKD. So the pharmacological treatment of hyperglycemia in adults with type 2 diabetes. This is a 2022 ADA Professional Practice Committee, and there is no difference in the 2023 guidelines also. So now coming to the poll, the technical team, I think I request.
Yes, sir. I have already launched the poll questions, sir.
Yeah, so
And I request and I
they are
request
one
all
second, one
delegates to
second.
observe.
Let me read it out, and okay, please,
Oh,
please,
okay, okay, sir.
please remove that. Okay, let me read out the question, then you can. Yeah, which class of the drug would you choose as an add-on to metformin for a middle-aged working professional recently diagnosed with type 2 diabetes without any comorbidities, and the A1C being 7.9%? You just have only a single choice here. You have to see the options are the first option is the SGLT2 inhibitors, and the second option is DPP4 inhibitors, and the third option is sulfonylureas, and the fourth option is thiazolidinediones. So they have given a case scenario that the middle-aged working professional who is recently diagnosed with the type 2 diabetes without any comorbidities, and the A1C is around 7.9. The patient is already on metformin. What is the best add-on therapy? Yeah, now you can start answering.
Now, sir, from I am sharing the results.
Yeah, please. Yeah, so 25% said it is SGLT2 inhibitors. They are not wrong actually. Okay, yes. And 50% have correctly said it is DPP4 inhibitors. And the Indian scenario again, they are not wrong by saying 25% the sulfonylureas. And very fortunately, nobody has said thiazolidinediones. So the correct answer is the DPP4 inhibitors. So this has got an evidence-based medicine. Let me tell you, the verified trial, which was the results of verified trial, which were the results were rolled in 2019. The European Association for the Study of Diabetes scientific sessions in the Barcelona, that is Spain, where I was also the principal investigator, and we rolled out the results of Verify, which says that the addition of this particular DPP4 inhibitor, that was done with vildagliptin actually. So the addition of vildagliptin to metformin, see what happens if you use only metformin. The metformin works only for a period of 2 to 3 hours, 2 to 3 years, sorry. And when metformin is combined with vildagliptin, in that study we were able to come to an inference that there is the increased durability and the longevity of the metformin to more than 5 to 6 years. So this is the inference from the verified trial. So based on the verified trial, the first add-on will be without any comorbidities with a A1C of 7.9. The add-on is to the metformin will be the DPP4 inhibitors, and the patient has some comorbidities, like either the patient is at risk of developing the atherosclerotic cardiovascular disease or the heart failure, and the patient has got established atherosclerotic cardiovascular disease and the heart failure, or the presence of the chronic kidney disease, and the patient has got some the liver problems, that is either in the form of non-alcoholic fatty liver disease or the non-alcoholic steatohepatitis. The drug of option definitely would have been the SGLT2 inhibitor. But in the absence of all the comorbidities, with the A1C of 7.9, the patient on metformin and without any comorbidities, it's inevitably the drug of choice will be the DPP4 inhibitors. And Indian scenario, it goes like what 25% of the doctors opined that sulfonylureas. It's not wrong actually, because even we have the abundant, robust, the evidence based data from the Carolina trial that was done by the Boehringer Ingelheim people, that the Carolina trial was done with the Linagliptin, the DPP4 inhibitor, and all the trials, the comparator was the placebo, but the active comparator in the Carolina was the glimepiride. That the study went on for 5 years. The Carolina, it's a cardiovascular outcome trials. So there are two trials done with this particular linagliptin. One is the Carmelina and the second is the Carolina. The difference between the Carmelina and the Carolina is that the Carmelina has the inclusion criteria of very high cardiovascular risk patients, and whereas the Carolina, the inclusion criteria is with the very low cardiovascular events. That is the only difference. Both are cardiovascular outcome trials, and for the first time in the history of cardiovascular outcome trials, a direct comparator was the glimepiride, which was seen in the Carolina, and the inference is that the linagliptin has shown non-inferiority in terms of cardiovascular safety when compared to glimepiride. But the only difference was there was the increased incidence of weight gain to a tune of 5 kilos over 5 years with the glimepiride arm, and there was significant the L1 to L2 to L3 hypoglycemias in the glimepiride arm, where there was no weight gain in the linagliptin arm. There was no incidence of hypoglycemia in the linagliptin arm. So we tend to go for a combination of the glimepiride or the glycoside with metformin to start with. So now we need to focus on the particular point that we need to select such a drug that it doesn't have the tendency to produce the hypoglycemias and the tendency to increase the weight. These are the two factors to be considered, and at the same time it should have the cardiovascular safety, at least not safety, it must be neutral. Like it should not induce the cardiovascular events, that it should not be like inducing the heart attacks, or it should not be increasing the incidence of heart failures, or it should not be increasing the incidence of heart hospitalization for the heart failures. Like you take some DPP4 inhibitors like saxagliptin, that is the one you should never use in the presence of heart failure. That is because that the Seva TIMI 53 has clearly shown that it favors the this particular the increased incidence of heart failure. So the right answer will be DPP4, and next add-on will be definitely this SGLT2 inhibitor. So try to avoid sulfonylureas in the present context, that the ADA always warns about the hypoglycemia. Hypoglycemia is no more welcome to any patient suffering from type 2 diabetes, or even otherwise even the type 1 diabetes, or the gestational diabetes, or the pre-gestational diabetes, or even the other specific types of diabetes. No case of diabetes we should welcome the hypoglycemias. So Kashish, can you just move the slide?
Yes, sir.
Yeah. Sometimes I'm able to, but sometimes I'm not able to, Kashish.
Okay, no problem, sir.
Yeah, please.
Can you see it, sir?
No, Kashish.
Hello.
Hello. Yeah.
Now can you see, sir?
No, I'm not. I'm not able to. I'm not able to see. I'm not able to move also.
Sir, I am
May, maybe the poll question has stuck the slide
sir.
passing. It
No,
seems.
sir. I am already close, sir.
Acha, you are already. Yeah, yeah. I can see that the poll is closed actually. Long
But
ago.
slide can visible to you, sir.
No, 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 no.
Just a second.
Yeah. Please take your own time, Kashish.
Now, sir.
No, no,
Hello.
Kashish. No. The session is over. Okay.
No problem, sir. You
Yeah,
can continue.
and extremely sorry, dear participants, for the technical glitches. So this slide shows whether one should choose the DPP4 inhibitor or an SGLT2 inhibitor. And now you can see the parameters and the advantages of SGLT2 inhibitors and the advantages and the disadvantages of the DPP4 inhibitors. And you can see the additional considerations at the bottom of this slide. The as far as the HbA1c reduction is considered, both the SGLT2 and the DPP4 inhibitors are intermediate. That is, it is neither very potent, it is nor the least potent. So it is in between. Like the usual reductions with the DPP4 inhibitors, that varies from 0.7% to 1%, and whereas the same the reductions with the SGLT2 inhibitors is also somewhere around zero point 0.9 to 1%. And when you take this particular hypoglycemia, both are neutral. I said the SGLT2 inhibitors and the DPP4 inhibitors are neutral to hypoglycemia. And the one take home message at this particular juncture I would like to give you is that the hypoglycemia is inevitable if you start SGLT2 inhibitor or the DPP4 inhibitors in the presence of insulin, in the presence of sulfonylurea. The patient is already on insulin and the sulfonylurea. When you introduce, especially the SGLT2 inhibitor, may not be the DPP4 inhibitor, which is very much favorable to this particular hypoglycemia it doesn't produce. But SGLT2 inhibitors, they inevitably cause this particular hypoglycemia in the presence of insulin and sulfonylurea. So it's always better to reduce the dose of insulin, reduce the dose of sulfonylurea before you introduce the SGLT2 or the DPP4, or else the patient will experience the incidences of hypoglycemia. And when you take this parameter weight, certainly we find the weight reduction with the SGLT2 inhibitors. That is the greatest favorable aspect of the SGLT2 inhibitors, because to start with the SGLT2 inhibitors, way back in 2013, where the canagliflozin was approved by the US FDA, and 2014 the empagliflozin and the dapagliflozin were approved by US FDA. And these are the three gliflozins, the SGLT2 inhibitors available in our country. And one more, the other the SGLT2 inhibitors which are not available in India but available in the US or the European Union are the A2-gliflozin and the sotagliflozin and the ipragliflozin and the bifragliflozin. These are all available in the United States of America and the European Union. And we have only three. So the weight reduction is to start with the started as the glucose lowering agents. Later on, we saw the blood pressure lowering effect of SGLT2 inhibitors, and we saw incidentally the weight reduction, that is to a tune of 3 to 6 kilos in a period of 3 to 6 months with SGLT2 inhibitors. Later on, we have seen the favorable effects on the heart actually in the form of the increased, the decreased incidence of the 3-point MACE as well as the decreased incidence of heart failure and also the decreased incidence of hospitalization for heart failure. And later on we found it to be like very useful in the progression of the diabetic kidney disease or the chronic kidney disease. And later on we saw the favorable effects on the liver where the NASH is reduced and the NAFLD is also reduced. So these are all the favorable effects. So that's why we call this particular SGLT2 inhibitors the pleiotropic drugs actually. The three pleiotropic drugs we have in the field of the entire this cardiometabolic renal continuum. The first drug is the one wonder drug is statin, which is the wonderful pleiotropic drug. Second thing is metformin. Metformin is a wonderful pleiotropic drug. Wherever you say any condition, there is role of metformin. And the third thing is the wonderful molecule of this particular this thing the decade is the SGLT2 inhibitor, and probably to the best of my knowledge we don't get any better molecule when compared to the SGLT2 inhibitor with so many beneficial effects, not only the glucose lowering, even the cardio renal and the metabolic and the hepatic continuum, and even it has got the effects on the hyperuricemia, so which is commonly seen in the patients suffering from type 2 diabetes. It decreases the hyperuricemia, which is a very very favorable point, and it improves the endothelial sensitivity and so on. And when it comes to the weight, the DPP4 inhibitors are weight neutral. So DPP4 inhibitors, they don't increase the weight, they don't decrease the weight. And next is blood pressure. I have told you SGLT2 inhibitors definitely reduce the blood pressure, either the nocturnal blood pressure, that is the nocturnal hypertension. It is very much beneficial. Even the daytime blood pressure, even the afternoon time and the evening time blood pressure, and the 24-hour control of the blood pressure is seen with this particular SGLT2 inhibitors. So this is going to help reduce the incidences of the cardiovascular disease by reducing the intensity of the resistant hypertension and the nocturnal hypertension. And when it comes to the DPP4 inhibitors, it is neutral to blood pressure, because many studies we have seen even with the Linagliptin that it doesn't influence the fasting blood pressure, or sometimes it has got the beneficial effect. So to some extent that in blunting the postprandial hypotension at least, so it doesn't let the patient get into hypotension. That is the favorable, the latest research results seen with this linagliptin. And coming to the cardiorenal outcomes, the SGLT2 inhibitors, they have, it is the established benefits we definitely see, and the DPP4 inhibitors established cardiovascular safety, especially the linagliptin. That's what I told. The Carmelina and the Carolina are the two cardiovascular outcomes which have shown the cardiovascular safety of linagliptin. And the route is both same, the oral, except the insulin and the GLP-1 receptor agonists, all are the oral route only. And the cost, and when you come to this particular SGLT2 inhibitors, after the AstraZeneca people have lost the case in the Supreme Court of India, so they have lost the patency, and all the generics have come into the Indian market. Like to the best of my knowledge, more than 60 to 100 companies are manufacturing this particular dapagliflozin especially. So ranging from the least being the cystopic, that is 5 rupees 90 paisa, to maximum being around 15 rupees. All the companies or somewhere around some 14 to 15 rupees. So when compared to the earlier price, it's very, very economical because it was around 52 rupees. Now it has come down drastically. And the DP4 inhibitors also, now the Vildagliptin is off patented, and now it is available at a very, very cheaper price. Like 50 milligram of Vildagliptin is available for 3 to 4 rupees, and the 100 milligram of Vildagliptin is available for 8 rupees to 10 rupees, so which is very, very economical. And the recent the research trials have shown that there was some discrepancy, some sort of ambiguity was going on with the 100 milligram of Vildagliptin, and now it is overthrown. The research results have shown that 100 milligram, the sustained release of OD dose of 100 milligram of Vildagliptin is equally efficacious and not harmful to the body, like you give either in the dose of 50 milligram BD or 100 milligram SROD, everything is same. So the additional considerations, let us see. If it comes to the SGLT2 inhibitor, should be discontinued before any scheduled surgery to avoid potential risk of decay. This is a very, very important point. See, there are certain contraindications for SGLT2 inhibitors, and we need to be very cautious and very methodical and very, very vigilant, because any surgery you cannot continue this particular SGLT2 inhibitor. It may cause dehydration, it may cause, because of the osmotic diuresis effect, it may cause the DKA, and the decay risk, all agents except the thiazolidine, but we don't use anything. See, any surgery, it's a dictum that we should stop all the oral drugs, and we should put the patient on insulin. That is the gold standard practice actually. And the risk of bone fractures, especially, it is not a class effect, it is a drug effect. That is the finding which we have seen in the canvas, and the canvas are that had showed the two problems. The one problem is mentioned, and the bone fractures with canagliflozin, and the second problem is the the LLEA amputations, that is lower limb extremity amputations, were more seen with canagliflozin, but not with the empagliflozin and the dapagliflozin. And the canagliflozin, the patients who have used the canagliflozin have shown an increased incidence in the grade 2 amputation, or the half foot amputation, or the above ankle amputation, or the below knee, or the above knee amputations also. And the as a class effect, it induces the genitourinary infections actually, either the in the form of urinary tract infections, or the candidial moniliasis, that is the candidiasis, either in the form of balanitis or fasciitis, or balanopasciitis in males, and the vulvitis or the vaginitis or the vulvovaginitis, the candidial vulvovaginitis in the females. And the important point is the risk of Fowler's gangrene is seen with the SGLT2 inhibitors. Already that is called the necrotizing fasciitis of the perineum, otherwise known as the Fowler's gangrene, which is a dreadful disease. If you don't attend to that, the very immediately, without meticulous wound debridement, without the strict control of blood sugars with the insulin, and the proper care, the patient succumbs to death. There is no option. So as of now, 19 cases of this the necrotizing fasciitis of the perineum or the Fowler's gangrene are reported to the US FDA so far. So it has warned all the manufacturers of this particular the SGLT2 inhibitors to probe deep into this particular issue. And the next is the risk of volume depletion and hypotension. This happens because of the osmotic diuresis. The patient gets into dehydration, automatically the patient gets into hypotension. That is the reason whenever you start the SGLT2 inhibitors, make sure that the patient doesn't have any sort of the history of the recurrent genitourinary infections in the form of urinary tract infections, or the candidial moniliasis, or the active infection is a contraindication to initiation of this SGLT2 inhibitors. And you have to caution the patients to maintain the genitourinary hygiene to avoid all these genitourinary complications, either it is the urinary tract infections, the bacterial, the complicated or uncomplicated, whatever it may be, and even this particular the candidial moniliasis. So, and all the time ask the patients to get adequately hydrated to avoid dehydration and to avoid the electrolyte imbalance, because all the time the osmotic diuresis may cause the electrolyte imbalance in the form of the low sodium, that is hyponatremia and all, and hypotension. And the bad part of this particular SGLT2 inhibitors are they tend to increase the LDLC, which is not at all desirable. But keeping the benefits of the SGLT2 inhibitor, you need to forget about the complications and the rise in the LDLC. So you have to be very cautious with this particular thing. Like you have to be very vigilant, and you have to constantly monitor the lipid profile, so that you should put the patients on statins to lower the LDLC and to see it reduces the triglycerides but increases the LDLC, which is not a favorable effect of the SGLT2 inhibitors. So if the lipids are not meticulously controlled with only this particular the statins, even you increase the dose of statins, it is not able to control. You add ezetimibe, and if that is also failing, if the patient has got hypertriglyceridemia, either you have to add the fenofibrates or the saroglitazar, and you can go to the PCSK9 inhibitors, the injectable PCSK9 inhibitors once in a month. If the patient is at very high risk of developing this thing, the 3-point MACE or the 4-point MACE or the 5-point MACE, whatever it may be, you have to use, don't hesitate. Even the 2023 guidelines, of the American Diabetes Association, the standards of medical care in diabetes, the first volume of this particular the diabetes care, the supplement 46 says that you have to use this particular PCSK9 inhibitors along with the statins and the ezetimibe to control the LDLC meticulously. And coming to this particular DPP4 inhibitors, and the concern is that pancreatitis has been reported in clinical trials, but the causality has not been established, and discontinue if pancreatitis is suspected. Especially this was more in the beginning actually. So this was more hyped actually. So the incidence of pancreatitis was hyped actually because it was not properly used in a patient who had already got one episode of pancreatitis. See, whenever you start the DPP4 inhibitors, you have to ask one single question: whether the patient had in the past any history of the acute pancreatitis or chronic pancreatitis, that is the clinical pancreatitis or the biochemical pancreatitis, that is in the form of the pain abdomen radiating to back, with associated with the vomitings and all, is a classical picture of either the acute pancreatitis or the chronic pancreatitis, or the acute and chronic pancreatitis. And the biochemical pancreatitis is nothing but the abnormally raised the serum lipase and the serum amylase levels. So in that particular patients, you should never initiate DPP4 inhibitors, because it may again trigger this the pancreatitis. And the second concern is joint pain. Yes, there are some minor problems like the upper respiratory tract infections like some common cold-like symptoms are seen even with the SGLT2 inhibitors or even with the DPP4 inhibitors. And the next slide shows the reductions in HbA1c with the SGLT2 inhibitors versus DPP4 inhibitors as add-ons to metformin therapy according to the baseline HbA1c, a systematic review of randomized control trials. And you can see the three bar diagrams, and the first one is the red one and the yellow one and the green one. The first bar diagram we are seeing is that is the Linagliptin 5 milligram was able to reduce the A1C by 0.7%, and the empagliflozin used in the dose of 10 milligram was able to reduce the A1C by 0.66%, and empagliflozin 25 6.2% respectively. See, there is some contradictory findings we find here, because that is very common. The first is the DPP4 standard dose, and the second is the low dose of SGLT2, and the third is high dose of SGLT2. Say, when you see this, the high dose of SGLT2 should reduce the A1C greater than the low dose, but here it is not so, because they see it depends on so many conditions, the race, the ethnicity, the environmental conditions, and the eating habits, the cultural variations, and the racial variations. So many factors coming to play, and the trials are done in different places, the different inclusion criteria and exclusion criteria. So the variations must be accepted. So when you come to the second bar diagram, that is done with sitagliptin 100, because that has reduced the A1C by 0.87%, and the etugliflozin, which is not available in India, etugliflozin 5 milligram was able to reduce by 0.8%, and etugliflozin 10 milligram was able to reduce by 0.73%. And the last one, you can see the same sitagliptin, because these two molecules, the sitagliptin and the etugliflozin, they belong to Merck, and the linagliptin and the empagliflozin, they belong to Boehringer Ingelheim. So these why the linagliptin and the empa and the clubbed together, and why sita and etugliflozin they are clubbed together is the reason that they belong to the one multinational company. The one is the Boehringer, and the second is the Merck. And see, etugliflozin 10 has reduced by 0.73%. See, supposed to be the more actually, because etu 5 has reduced by 0.8. But I said the reasons why you have got a diversified the findings and the reductions in the A1C is so diversified because of the various factors. And last one is sitagliptin 100 has shown the reductions by 1.1%, and the etugliflozin 5 by 1%, and etugliflozin 15 milligram by 1.1%. So here I would like to give you the take-home message that the particular the etugliflozin, the therapeutic dose is all the time 15 milligrams, and the sitagliptin all the time it is 100 milligram, and the linagliptin is all the time 5 milligram. And all the trials that are done with empagliflozin are done with only 25 milligram. Dapagliflozin all the time it is done with 10 milligram. Etugliflozin all the time done with 15 milligrams, and the canagliflozin is all the time done with 300 milligrams. Never ever with EMPA 10, with the DAPA 5, and Cana 100, and etugliflozin 5 or 10. So in this connection, I would like to make one point very clear, that the favorable DPP4 inhibition as well as the SGLT2 inhibition is seen in Indians, especially the Indians. We are called the Asian blacks by the Americans or the Britishers. They call us the Asian blacks and the African blacks. So the DPP4 inhibition, a better DPP4 inhibition and a better SGLT2 inhibition is seen in the Asian population, and either the Chinese or the Japanese or the Pakistanis or the Bangladeshis or the Sri Lankans, or the Philippines, or the whatever it may be, the Korea, the South Korea, North Korea, what are all the countries are there in this particular the Asian belt, and especially the hub of this thing is the China and the India, and the US in the third place and Pakistan in the fourth place. So the out of top four, three countries are in the Asian belt actually. So when compared to the Caucasians, that is so called the whites, the United States or the UK whites, the DPP4 inhibition is more and the SGLT2 inhibition is more, resulting in greater reductions in the fasting plasma glucose or the postprandial plasma glucose, and the HbA1c also is reduced to the maximum levels when compared to the whites or the Caucasians. So the HbA1c reduction of DPP4 is at par, at least non-inferior with SGLT2 inhibitors. This is the take-home message. And comparing the SGLT2 inhibitors to DPP4 inhibitors as an add-on therapy to metformin in patients with type 2 diabetes, it's a systematic review and meta-analysis. And you can find the 7 trials met the inclusion criteria. The primary outcomes were changed in hemoglobin, the A1C, that is HbA1c, at around or less than 26 weeks, and around or more than 52 weeks. And on the right hand side, you can see that on restricting the analysis, according to the baseline A1C, the results favored. That is, the it says the HbA1c is less than 8.5%. You go for DPP4 inhibitors, and if the A1c is more than 8.5, you go for the SGLT2 inhibitors. So this was published in the Diabetes and Metabolism in 2018. So it's around some 5 years or 6 years old data. And now the latest the results, the research results, they say that irrespective of the baseline HbA1c, whether it is 6 or 6.5 or even the 7, whatever it may be, you have to start the SGLT2 inhibitor very early in the course of type 2 diabetes mellitus, so that you can pass on the benefits to the patients, like the reductions in the A1c, reductions in the blood pressure, reductions in the weight, the decreased incidence in the 3-point MACE or 4-point MACE or 5-point MACE, or the heart failure or the hospitalization for the heart failure, the hepatic benefits, and then the kidney benefits, and the good effects in reducing the hyperuricemia, you can have only when you start very early in the disease course, not in the later part of the disease course. If the duration of the diabetes is more than 20 years and you start the SGLT2 inhibitor, you don't find the benefits at all. If you start, the duration is less, the patient comes to you as soon as you start a triple drug combination of metformin plus DPP4 inhibitor plus SGLT2 inhibitor. Now several companies have come up with the 500 or 1000 milligram of sustained release of metformin with the 100 milligram of the sustained release of vildagliptin, or 100 milligram of sitagliptin plus 10 milligram of dapagliflozin. So if you can go with this triple drug combination, see, all the three drugs, I mind you once again, they act on the extra pancreatic mechanisms only. They never touch the pancreas. Unlike the sulfonylureas, they don't act on the pancreas, and thereby you are minimizing the pancreatic bankruptcy, and you are thereby you are the minimizing the living beta cells, that is the which favors slowly the proliferation of the active beta cells or the living beta cells. So thereby you can avoid pancreatic bankruptcy, and that stage the patient has to be only on insulin. And one more valuable drug, if it is used judiciously, is the pioglitazone, the thiazolidine in low doses. Like you start with 7.5, 15, It's enough. So it's a very good insulin sensitizer. So even better than metformin, but you have to be very cautious when you start. That you have to exclude the volume overload states like the CCF or the chronic renal failure or the chronic liver disease or chronic liver failure. So you have to avoid the volume overload states, and then only you can start this particular the thiazolidine. The one and only that is available for us is only the pioglitazone. And except in cases of the NAFLD and the NASH, you don't need to go to the maximum dose, wherein it is very much inevitable that unless you go to the maximal dose like 45 milligram or at least 30 milligram, you cannot have the beneficial effects as far as the liver is concerned, either in the form of NAFLD or nowadays we are calling it as MAFLD also, or the NASH. So moving on to the next slide, they relook at DPP4 inhibitors in the era of SGLT2 inhibitors. It is published in the World Journal of Diabetes 2022. So while long-acting GLP-1 receptors have shown a favorable HbA1c lowering compared to DPP4 inhibitors, there is no clinically meaningful HbA1c lowering difference between SGLT2 versus DPP4 inhibitors that we have seen in the bar diagrams, that is the Linagliptin versus the empagliflozin and the sitagliptin versus the A2gliflozin. And moreover, the glucose lowering potential of SGLT2 inhibitors gets compromised with a progressive decline in the renal function, unlike DPP4 inhibitors. And furthermore, the HbA1c lowering potentials of DPP4 inhibitors is favorable in people with type 2 diabetes having a modest HbA1c, the baseline HbA1c around 8 to 8.5% compared to the SGLT2, which lowers HbA1c larger in a background of higher baseline, that is HbA1c of around 8.5% and 9%. See, this characteristic phenomena is seen with almost all the drugs what we have A to Z we have in the diabetes. The funda is higher the A1C, the reductions are more. The lower the A1C, the reductions are less. And these findings suggest that the role of DPP4 inhibitors in the management of T2DM cannot be completely ignored even in the era of SGLT2 inhibitors. Yeah, this is the take-home message. See, we focus on SGLT2 inhibitors. At the same time, a combination of DPP4 along with the SGLT2 is much synergistic. It is not additive. It is definitely synergistic. So even in the era of SGLT2, this is the era of SGLT2 inhibitors, but you cannot forget the role of DPP4 inhibitors. And now the coming to the poll question, looking at the previous data, which DPP4 will you deploy for the aforementioned patient. So again I read, looking at the previous data with the DPP4 inhibitors, will you deploy for the aforesaid patient? So it is linagliptin, sitagliptin, the vildagliptin, the alogliptin, and saxagliptin. The poll starts now. Please answer your question. It is a single answer, not multiple options. Okay, only you have to answer one gliptin.
Now, sir, I am sharing the result.
Yeah, please, Kashish, please. Yeah, 100% they said it is linagliptin, which is absolutely right. Why you need to go for a molecule like linagliptin is, this is the only one molecule that doesn't require any sort of down titration, even in the presence of any degree of EGFR, any stage of the diabetic kidney disease or the chronic kidney disease. Let it be stage 1, stage 2, stage 3A, stage 3B, stage 4, stage 5, that is end stage renal disease or the end stage ESKD or ESRD, end stage kidney disease. This is the only drug that can be used along with insulin without any down titration. This is the beautiful aspect of linagliptin. You start with 5 mg, you stay with 5 mg forever. You don't need to down titrate, because all the other molecules, in the cases of renal failure, as the EGFR goes down, as the staging goes up, you have to reduce, like sitagliptin, from 100 you have to come down to 50. From 50 the EGFR is going still down, like below 45, you need to go down to 25. So frequent changing in the dose may affect the this particular the glycemic variability and the changes in the A1C also. Likewise, the vildagliptin, if it is 50 milligram, the patient is on 100 milligram SR OD, you have to come down to the 50 milligram OD, and likewise allogliptin and saxagliptin. So this is the real renal gliptin, which doesn't require any sort of down titration. And second thing is, the beautiful aspect is, this drug need not be discontinued when the patient is on dialysis, whether it is peritoneal dialysis or the hemodialysis. You can continue linagliptin along with insulin, and even during transplant also, the kidney transplant, you can use this particular molecule along with insulin. The only one molecule that can be used, the oral agent that can be used even in the ICU setting, is the linagliptin. And the best part of linagliptin is, there is an entity called the PTDM, that is post transplant diabetes mellitus, so which is seen after the kidney transplant actually. So post transplant diabetes mellitus, the drug of choice is again the linagliptin. So keeping all the favorable effects of linagliptin, the keeping the cardiovascular safety and the renal safety, so linagliptin becomes the drug of choice. Next slide. Next slide, please. Hello, Kashish?
Yes, sir. I have already changed the slide, sir.
Yeah, but it's not okay, it's not moving. This slide shows the linagliptin, one dose fits all. Usually, what I used to say in all my speaker programs, one size doesn't fit all. But as far as the only exception being the linagliptin, because linagliptin, one size, one dose fits all. So you can see the renal impairment, and you can see the multiple the gliptins given here, the allogliptin, and the linagliptin, and the sitagliptin, and the vildagliptin, and the saxagliptin. And you've got all the cardiovascular outcome trials for all these things. Like except for vildagliptin, you have all the, like allogliptin has got the examine, linagliptin has the carbolina and the carolina, sitagliptin has got the teco study, and the vildagliptin, that is the only one that doesn't have this particular the cardiovascular outcome trials. And saxagliptin is Savar Timmy 53. And you can see that the mild EGFR started. So EGFR more than 50 ml per minute. So you can see the different it is going down, and 30 to 50 ml and less than 30 ESRD renal dialysis. That's what I said. So the allogliptin, from 25 it has come down to 12.5, from 12.5 to 6.25 and all, and linagliptin remains same, that is 5 milligram all through the disease process. Okay, and the sitagliptin from 100 to 50 to 50 to 25 already mentioned. Vildagliptin, the same thing, 50 milligram BD has become 50 milligram OD. And saxagliptin, you start with 5 milligram and you have to come down to 2.5. and it is absolutely contraindicated in ESRD and renal dialysis. And when you take this particular the hepatic impairment, whether it is mild, moderate, or severe, the same things, the allogliptin, the mild and moderate, it is 25, but it is not recommended in the severe hepatic impairment, that is, it is contraindicated in chronic liver disease, the CLD. And linagliptin is the one that can be used all through this particular mild, moderate, severe hepatic impairment. And sitagliptin 100 milligram can be used in mild and moderate, and you need some sort of caution when the severity increases, that is in the cases of chronic liver disease. And vildagliptin is not recommended because it increases the liver enzymes actually. And the saxagliptin, the mild, you can use 5 milligram, and you have to be very cautious when it comes to moderate, and should not be used in severe cases. Yeah, next slide please. And these are all the COVTs that I have said. The COVTs of linagliptin has included a broad set of T2DM patients with and without cardiorenal comorbidities. You can take this exam and you can see that is the for allogliptin, Seva TIMI 53 is for the saxagliptin, the Tecos is for the sitagliptin, and the Camelina and the Carolina are for this particular the linagliptin. Next slide please. So you can clearly see this, the graph shows that the linagliptin was associated with a significant 14% reduction in albuminuria progression. You can clearly see that the black is the placebo and the purple, the pink is the linagliptin, and the reductions in the albuminuria progression is by 14%. So the p-value is 0.0034, that is statistically very significant. Next slide please. So again a poll question has come, and what percentage of your T2DM patients present with concomitant chronic kidney disease? The answers are up to 20%, and 20% to 40%, 40% to 60%, and more than 60%. Now we can answer the question please. It's a single answer, okay, not multiple. Is it over, Kashish?
Now, sir, I'm sharing the result. Yes.
Yeah, you can post the results. Yeah, most of the doctors have answered it very correctly, that 80% said it is 20 to 40%, and some 20% said it is 40 to 60%. Maybe I don't say that it is a wrong answer, but the most appropriate answer would be the 20% to 40%, because most of the randomized controlled trials have shown that the type 2 diabetes, the incidence of the CKD is somewhere around some 34.6%, that is roughly around 35%, whereas the 20 to 40%, whereas in type 1 it is the 20 to 30% actually. So the right answer is 34.6%, that is approximately 35%. So 20 to 40 is the correct answer, and you can please take it off, Kashish. And the inference is 1 out of 3 patients suffering from type 2 diabetes, they have the chronic kidney disease or the diabetic kidney disease. So this is the take home message. So how prevalent this particular the chronic kidney disease is. When you take the incidence of cardiovascular disease in type 2 diabetes, it is 86%. When you take the incidence of retinopathy, it is 96%. The maximum is with that. And the sensory neuropathy or the motor neuropathy or the autonomic neuropathy clubbed together, a broad heading like neuropathy is somewhere around some 30% to 50%. So this slide shows the with linagliptin, fewer patients initiated an increased insulin dose. So you can see the same black, the initiation. Kashish? Kashish, this slide shows the linagliptin has the broadest clinical evidence of efficacy and safety in the DPP4 class actually. You can see the monotherapy, the dual therapy, the triple therapy, and the high CV risk and heart failure and high kidney risk. And you can see the vildagliptin. See, monotherapy it is okay, dual therapy it is okay, triple therapy it is okay, any number of therapies all are okay. The vildagliptin and the saxagliptin and the teneligliptin and the sitagliptin and the linagliptin are okay for either monotherapy or the dual therapy or the triple therapy or 4 drugs or 5 drugs with insulin, without insulin, with GLP-1 receptor agonist, whatever it may be, they are all okay. But the problem comes when you come to the comorbidities and the complications. Like vildagliptin is uncertain in all the 3 categories, the high CV risk and the heart failure and the high kidney risk. And the saxagliptin, high CV risk, it is okay, but heart failure, I told you, it is danger signal, that is this safety signal. You are not supposed to use this particular molecule as per the Seva TB 53. It induces heart failure, so you should never use this particular saxagliptin, and it is uncertain in high kidney risk. And teneligliptin, high CV risk, it is so. This is the Indian gliptin actually. This is not the Indian gliptin. This is the Japanese molecule actually, not from the pharma industry. This is from the automobile industry. The Mitsubishi has got this as a byproduct actually. This is the history of teneligliptin. Is used in Japan. It is approved by the Japanese FDA and the Korean FDA and the Indian FDA. It has got sparse studies, and though the studies are coming up, these are all pharma based, biased. The cooked up results they are showing. Like earlier they said it is 20 milligram, and now they say you can go to the maximal dose of 40 milligram. So the greatest disadvantage of teneligliptin is it increases the QTC prolongation, which leads to ventricular tachycardias like ventricular flutter or ventricular fibrillation, and the patient dies with sudden cardiac death, that is called SCD. So please try to avoid teneligliptin. So far, I have not generated even a single prescription of teneligliptin so far. So you want to go for the economical versions, you can go for the generic brands, that is off-patented vildagliptin, off-patented the sitagliptin, than this particular. When the price is the concern, you stop teneligliptin, you go for vildagliptin and sitagliptin. When the price is not a problem, go for the best gliptin, the real renal gliptin, and the wonderful gliptin, linagliptin. So again teneligliptin, so I don't want to talk about teneligliptin first of all. And sitagliptin, so it is safe in high CV risk, and but it is safe in heart failure also, because TECA showed that. But when it comes to kidney risk, it is uncertain. You need to down titrate. And how far it is beneficial, nobody knows. And coming to the linagliptin, see, you can see all the green zones. So like it can be used in any clinical scenario, either the monotherapy or the dual therapy or the triple therapy, or the patient is with high CV risk as evidenced by the Carmelina and the Carolina, and the heart failure and the high kidney risk. You can use this particular linagliptin. Next slide please. So in hospitalized T2DM patients, linagliptin arm had more blood glucose readings within the range compared to sitagliptin. A retrospective single clear observational study was performed where 100 hospitalized patients were studied, and in a subgroup analysis, patients who received linagliptin plus correctional insulin had more blood glucose readings within the range of 140 to 180. See, the inpatient setting is totally different. The range you have to maintain in inpatient setting or the ICU settings is, it should be in between 140 to 180 milligram per deciliter. Only 70% of this sitagliptin orders were appropriately dosed based on the EGFR, and the results favor the utilization of linagliptin in the setting, considering it does not require a renal dose adjustment. You can clearly see that the blood glucose readings within the range, that is linagliptin 50% and the sitagliptin 36%. Next slide, please. And again a poll question. And do you agree that linagliptin has the broadest clinical evidence of efficacy and safety in the DPP4 class? Strongly agree, agree, neutral, disagree, strongly disagree. Now I request the participants to answer this poll question, please.
Now, sir, I'm
Yeah,
setting
please,
the
please, Kashish. Yeah, everybody said strongly agree. Yes, it is the right answer. You have to agree very strongly that it is the drug. Yeah, please, next slide, please. So, what are the considerations for choosing? It is another poll question. What are the considerations for choosing linagliptin among as the other gliptins? It is a multiple choice answer. Actually, you see the multiple answers are like. Okay, can you please remove the poll question, Kashish?
sir. Yes, sir. Sir, can we wait for 20 seconds, sir?
Yeah, finished. Okay, done.
Okay, so,
So,
I am now setting the.
yeah. So 60% said flexible to use monotherapy, dual, triple, and yes, 100%, 100%, 100%, 100%. Everybody said, yeah, all answers are very relevant, and everybody has answered it very correctly. Yes. So we'll go to the next poll question.
Sir, this is the last poll question.
Last poll question. Okay, then fine. Are you aware about the recent price rationalization done for Andero and Anderomet? Andero is nothing but the lupin molecule of linagliptin, and Anderomet is the lupin molecule of linagliptin plus metformin. Yeah, you can answer actually.
Now, sir, I'm
Yeah,
selecting.
please, you share the, yeah. Everybody said yes, the price is reduced. It is reduced by 20 rupees actually, from 50 rupees. It has come down to 30 rupees 50 paisa. And thank you so much for your patient listening. And thank you so much, Lupin, for giving me the opportunity to be the speaker this evening. And now, ma'am, I'll hand over it to ma'am. Okay.
One good thing is, sir, this is the first CME in this 2023.
Oh.
And I want to thank